So welcome everyone, welcome to the monthly improvement forum. If I go to the agenda next, Victoria, and we'll talk through what we're doing. So for those of you who haven't joined us before, my name is Maria Riley. I'm the Associate Director of Strategy and Improvement for the Trust and have the pleasure of leading the Academy. We follow a usual format every month, so we're going to do a spotlight on some presentations of improvement work that's been conducted across the Trust. So we've got Carolyn, Richard and Hannah talking to us. Stacey is here and will talk to us about some of the improvement that she's facilitating and how you can get in touch with her if you've got an improvement idea that you want to bring to life. We'll talk about the improvement training programs and then just finish off sharing and celebrating a couple of things that we've got in some slides. But if you're here and you're working on something that you want to kind of speak about, have a think about whether you want to just have a conversation in that last section about anything that you're working on that you want to share and celebrate, or that you'd like support with from an improvement perspective. So we'll just go straight on and I'll hand over to Carolyn to talk about there you go. Thanks.
Thank you.
To attend anywhere, Carolyn. Thank you.
Yeah, no problem. So this was part of a project in Women's and Men's Health Physio that we were keen to do for quite a long time. So we'd been looking at doing a video appointments, and we'd looked at a couple of years ago developing a project with patient representatives, and also went to the annual members meeting and surveyed people. And there was lots of positive response from people across all age groups. And then early 2020, we became part of the National NHS Attend Anywhere project and started with a very small group of postnatal mums. And then obviously COVID hit, and so it got rolled out much more widely to all of our people. So then this slide's just showing the response to, we set up some SurveyMonkey surveys that went out automatically. And actually we did collect quite a few more responses, but because we've only got the not paid for version, we can't access all of the responses. So we ended up with 72 responses from the therapists. And overall, it was fairly positive. So in terms of sound quality, for the majority of people, it was good, but there were sort of poor or very poor sound quality for about 14 respondents. Video quality was slightly better. And although everybody wasn't using screen share, they generally found it really good. And benefits that therapists were saying were sort of taking less time, finding it less stressful, that they could include most of the elements of assessment that they needed to for the condition. And on the whole, it was felt that video was better than phone because it offered the chance for looking at movement, looking at pain location, teaching exercises, checking exercises. And also we did quite a few diagnostic self-tests, and so we were able to supervise that. And as well, one of the other benefits that we found with the postnatal mums is that we were actually picking up, whereas we maybe wouldn't be seeing them in the first few weeks, we were picking up some things like early signs of infection. So then disadvantages, especially initially, people were finding it much more stressful, and also that you couldn't do, sorry, I'm getting my voice coming back to me now. I don't know if everybody's on mute. That's better, sorry. You couldn't necessarily always do all the assessment that you did want to do. And the main themes of the comments were technical difficulties, so like a lag, a loss of connection, that things were out of sync, or that the video was freezing and you had to move to phone. Our inexperience at the time with the platform, so that made it a bit more stressful. Assessment difficulties, as we were saying, but including being able to sort of angle the video properly so that you could see what people were doing, or so that you could demonstrate things, and also the time issue. So next slide, please. For the majority of cases, 65%, there was no time saved by being on the video, but for 31%, about between 5 and 10 minutes was saved. So although this is sort of quite a small amount over the range of different appointments that we saw, it could potentially be beneficial if it was scaled up over seeing a lot of people over video. And again, there were some free text comments that linked to technical difficulties, a slightly disjointed way of working, and a feeling that for some specific patient groups it was working quite well, but not as useful for all conditions as face-to-face, but it was very much felt to be a good option, especially at the time because of COVID. And on average, therapists were scoring the delivery of the care as 7.5 out of 10, so really happy with the standard of care that they could give. Next slide, please. So patient responses, we had 40 of these. And the demographic of patients that it came from, it was generally people between 25 to 35 years old and nobody over 75. But actually, I don't think this was to do with the platform that it was on so much as the fact that after first lockdown, we only mainly saw antenatal and postnatal urgents and our other referrals stopped. So we weren't seeing the whole range of patients. Patients felt that 78% of them felt that it was very, very easy, and they rated it as 9.3 out of 10. And overwhelmingly, they were happy to use it again if it was offered. A few little issues in terms of the connection being difficult or things not working as they liked with microphones, or the fact that they had to download the Chrome browser to use it. But the vast majority were very satisfied with information and everything that was sent out as well. There were a couple of hitches early on with our admin processes, but we've ironed those out. Next slide, please. So benefits that the patients saw, over 76% felt that it was more convenient, so they didn't have to take out time from education or from work or arrange childcare or arrange other care. They didn't have to worry about parking or travel. And so for half of them, they found it a much less stressful experience overall, and 65% felt that it was a more comfortable waiting experience. And the majority of patients, so over 70%, felt that there were no disadvantages at all. But the people that did feel that there were disadvantages, it related to either the setup in their homes, so they found it really difficult to carry out the things they needed to demonstrate or to carry out exercises because of the space in their location, or issues like somebody else rang them during the call and actually the call dropped out, or getting the sort of the closer feedback from the therapist in terms of being really sure if they were doing the exercises correctly. And also comments were made about it being less personable, or I feel that I'm missing out on a physical examination. I would have preferred an examination which can only happen in person. Time savings were considerable for the patients. The majority saved between 1 and 2 hours. I was trying to collect about money saving as well, but because of the way that the original survey was set up, it was an either or question for some reason, so people couldn't comment on that. But on average, patients rated it as 4.7 out of 5 stars, and 71% of them gave it 5 stars. Next slide, please. Thank you. So overall, the patients were sort of really pleased with the high quality of the appointments, and they were really appreciative of the service having been developed and carried forward. And I guess my conclusions about it are that COVID itself was a really good spur to sort of a very fast rollout and a wider acceptance. And because of that, we've had a lot more chance to evaluate what it's good for, what the video works less well for. It's also driven forward other service evaluations. So alongside to support the video, we've developed screencast videos and demonstration videos of different exercises. And so actually that's really useful for our whole patient group. Most therapists were really satisfied, and actually when it's working well, everybody really loves doing it via video. But there are still a few issues with technical hitches, and it's hard to know where this is, because I know that when therapists have worked from home, actually it's tended to work really, really well. And then sometimes in clinic, it's just not working very well. And whether that's issues our side or issues on the patient's side, we do sometimes have to move on to phone. So I think as a group, the therapists and also patients, we've become all a lot more used to doing things remotely, and we've got a lot of systems in place to do that. So I think confidence on both sides has increased a lot. And really, it's a really, really great resource that we wouldn't want to lose, but we do feel very much that patient selection is extremely important, and that it's not appropriate for all patients or for all interventions for the same patient. Right, thank you.
Thank you, Carolyn. Really interesting reflections on so many fronts there. It's brilliant to see just a real focus on the patient perspective and how they feel about and see those appointments, and also our people side of things. In terms of the time saved, that's an interesting one, isn't it, that we've been thinking about a lot, because there was this perception pre-COVID that if we switched to a lot of virtual, it would be time saved, and the reality is that it hasn't been. But whether that would be for the future, once we get more efficient and once we get greater volumes and we're able to cohort clinics of whole video appointments in a different way, is interesting. I think we definitely still have issues to resolve in terms of our equipment around the trust. So if you are having problems in a particular area, let us know, and we can get the team to come and do a bit of a site survey in an area, perhaps while you're doing a clinic, and then follow that through. That's definitely something we've used in other places where we've had problems, and we can get an engineer to kind of sit with you and work out what it is. And definitely the patients getting the choice. I think we recently did a Derbyshire dialogue session listening to our patients, and they definitely wanted choice. You know, some of them do prefer to see a face and feel more comfortable than with a telephone conversation. So it's definitely our ambition for the future to kind of extend this out. It's great to hear how you're using it and how the patients feel the values within that. And I think we definitely want to share that learning with other clinicians across the trust who perhaps haven't experienced video to date. So it'd be great to use you to get in touch with other people and share your experience, if that's okay, as we start to spread across some of the services who aren't currently using video to the same extent that you are.
Yeah, that would be totally fine. Yeah.
Brilliant. Are there any questions for Carolyn? No, but thank you very much, Carolyn. We hope to hear from you. I did wonder, actually, while you were talking, whether group clinics is something that you're going to be focused on for the future, because Attend Anywhere going forwards is going to have some new functionality for group clinics beyond kind of about July time, and we think that's coming. Is that something that you could expand in the service?
Yeah, I mean, that's definitely something that we've been talking to Richard Grattan and other people about. So we're going to trial. We need them, because at the moment you can only have 6 people, can't you? So we need the groups to be bigger than that. But we're aiming to trial over the next, before it comes in with the 30 people, so that we've ironed out some of the issues that there might be about running groups, so that our information groups can be offered in that way. I mean, particularly if we're still having to socially distance and things like that, with bringing people into clinic, but as another option. So that should be good, yeah.
Great. So given you might be an early adopter of that, given where you're already at with the service, it'd be great to hear from you about how you pilot that and how you use it in some of your first areas, and bring you back to talk about that.
Yeah, no problem.
Lovely. Well, thank you so much, and we hope to see you back again later in the year. Same day emergency care then. So Richard Hopkins, you're going to talk us through your experience today.
Yeah, so hi, I'm Richard. For those of you who don't know me, I'm one of the acute consultants. I apologise to anyone on the list who's already heard bits or some of this talk. I'm probably going to duplicate it. So I'm just going to run through the same day emergency care perfect week that we did. I'd put a list of the project group there, but there was about 30 or 40 people involved on the actual week. So lots of people involved, and I couldn't list them all. So next slide, please. Thanks. So the aim of the perfect week was really to test lots of different things in one week and really see what an expanded service would look like for the medical same day emergency care unit, how many patients we could get through, what sort of staffing would need to cater for this, and try and describe what space we'd need to facilitate that. We used a perfect week model, which essentially involves trying to make everything as efficient as possible, slightly overstaffing the service so you're not going to run into barriers and have to turn people away just because you don't have people to see it. So make it as safe as possible to test all of these ideas in one go is really the gist of it. Next slide, please. So things we looked at during our perfect week, we tried taking referrals directly from lots of different patients. So different ways of bypassing or making sure patients didn't have to come through ED or go to EMU, coming straight into us. So triage were referring directly to us, UTC. We had referrals direct from the EMAS paramedics, DHU and 111 could all refer directly into us and would see patients without them needing to go through those other various routes. We trialled a system of consultants taking referral calls. So there was a referral line directly into SDEC, but the consultants took the other calls, and then lots of different staff coming to work with us, ACPs, EMPs, and our physicians associates from EMU. We had a dedicated porter for the week. We had dedicated reception staff cover for the week as well, which freed up a huge amount of clinical time. I think we all quite appreciated how much nursing time has been taking up doing those roles until we put those in and freed them up. And a little bit of informal agreement from radiology just to provide some extra cover for us as well. So next slide, please. I've put a smattering of the information we got from the week on here because there was sort of a huge amount of data generated. So if I talk through the three graphs starting in the top left, this is a run chart, and I've just taken the first 4 weeks of the last 3 years really and put them on here. So you can see our 2019, that's what we've been using as our baseline, median numbers of about 79 patients a week and varying up to about 105, 110 at the top end. 2020, obviously an interesting year. We had a rather large dip due to COVID, so we can write that off. It's not a particularly useful part of the graph. And then where we'd got to with the previous things we've been running, we'd bumped our baseline up to just shy of 100 patients on average, with a peak of 120 prior to the perfect week. Perfect week, we managed to get through 189 patients, which was a huge achievement for everybody. The most patients we had through in one day was 41, where our previous maximum was 28. And you can see the tail of the graph is the 4 weeks following on from the perfect week, where we've really had a sustained increase from it. So we're still getting the residual effects of all those extra referral routes and people being aware of the service and referring directly into us. We then looked at the outcomes of patients. So we discharge 80% of patients on their first attendance, which is pretty good. 14% return either for review or for a test, and I think that's an area we can probably still work on and shrink, particularly those return for a test patients down, either bringing them back the next day rather than seeing them the first day, or making those tests more available. We admit about 5 to 6%, which is well within the realms. We could probably even let that creep up to around 10% without anyone being too concerned about it. So good results in terms of we're doing what it says on the can, same day emergency care. We're sending people home and treating them safely. Then the graph at the bottom there is looking at the number of patients by condition and the time we spend in the time they spend in the department. So the blue bar chart is the number of patients with that particular suspected condition. The cross is the average amount of time that patient or that group of patients spent into the department, with then the error bars in green either side of that. So this has really shown us there's a lot of variability in what we do. So we've got the DVT patients who are by far our biggest group, 55 of them through the week. The average amount of time they spend in our department is 2 hours, but that varies between 20 minutes and I think that top bar is hitting somewhat over 5 hours. Um, and there are some explanations to that, but it's been really interesting digging into that to try and find out how we can reduce that variability. And that's one of our next focuses, is to look at those condition-specific reasons why people might be staying in the service for a long period of time. There's lots of other data we've gained from this, but I can't go through it all in 10 minutes. Next slide, please. So the main things we've learned from our perfect week is we need to do a good bit of focus on staffing. Our STEC nurses are nurse leading 40% of our patients, so we need to support them and make sure we've got a trained STEC nurse on 7 days who can see and manage that workload. Physicians associates, AMPs, EMPs all worked really well within the STEC team, and we're now deciding which roles we're going to introduce as a regular staffing workforce. As I mentioned briefly, having the dedicated receptionist and portering time freed up a huge amount of clinical time that let our nurses get on with nursing or treating patients, and that's something with that now embedded. We've got a regular receptionist in place. The portering thing is probably slightly harder to justify given our numbers, but that's something we can look at as sort of a wider thing. We had really good success with the direct referrals, particularly from the front door, triage and UTC, and that's something that's carried on. I think there's a lot of enthusiasm from people just to send people straight into a service rather than having them go round the hospital. The EMAS referral routes, there were slightly more mixed results, and I think we did have some successes with it, but I think a lot of the EMAS group of patients, people picked up by an ambulance, probably need a route to directly refer into EMU, and that's again something we're going to look at and work on. Looking at our environment, we've decided our space, although better than where we were, isn't still quite optimal. It will limit our expansion to somewhat less than 40 patients a day. On our really busy day on the Friday where we had 41 patients, we had a couple of people who were getting slightly concerned with the social distancing. There was a struggle for actually people being seen in consultation rooms. So we were already limited just within the sort of realms of the trial we did. So it's something we need to look at as we plan to expand. And then changing in timings, trying to smooth out peaks. So we've got a bit of work. We might be able to push that 40 with doing some internal jigging around and efficiencies, but I think that's probably where we're going to end up in our current environment. And then technology is the next big focus. The access to real-time data, so it's really great having that information of our variability and how long patients spent in our department, but it's a snapshot. We can't ask people to collect that detailed level of data on a daily basis. It was very time consuming, so it would be really handy to have that at our fingertips on a regular basis but collected automatically. One of the other bits of work that's going on at the moment is an electronic take list, so hopefully we'll be able to see where our patients are, how many are waiting from wherever we are, so not all having to continuously come back and congregate at a whiteboard, which obviously slows everything down. Next slide, please. So our next steps, we've in the process of writing a business case for our increased staffing, and that's mainly to allow a consistent service so we can keep expanding it, but with everybody knowing it's going to be a reliable, consistent service going forward. We're doing some trials around changing consultant hours, trying to increase our numbers that we can see in the evening where there's that big rush from ED, though our main aim is to pull those patients straight to us before they go to ED. There's still going to be that large group of patients who end up there who are then referred on to the acute take. And we need to explore the impact that has because the consultants currently cover the acute take. As I mentioned, exploring space more efficiently and then just really maturing a lot of the relationships that developed during that perfect week and getting those referral processes done more smoothly, maybe even taking out the need for some of those phone calls to take place and sort of allowing people to refer in more directly, but that's something for the future. A few more trials in the pipeline. The midline service I just want to plug is up and running and starting out of SDEC. So if you've got people who need a midline, that service is now available. And we're going to be soon doing a trial of admission avoidance in heart failure patients by allowing them to come up to SDEC, have daily intravenous diuretics, which will be a really interesting bit of work to see if we can save bed days on that as well. I think that's my last slide. So any questions?
Thanks, Richard. Brilliant presentation, brilliant data. I think a couple of things that I reflected on when you were talking. First is the change currency of our improvement for the future, and I've been talking in our improvement delivery group and with our director of finance yesterday about how we start to demonstrate that the improvement outcomes that you're talking about here and have demonstrated through that service translate into improved value for the system, whilst it's not necessarily pounds and pence improvement, and how we start as a system to recognise that shift more and how we demonstrate that. So we'll work with you on doing that in terms of what that means in terms of overall system benefits for the future. For the benefit of those who weren't with us this morning, we've obviously been talking, haven't we, about how we can share your learning with surgical colleagues in terms of the surgery SDECs. We're really focused on supporting that shared learning and making sure that we learn the lessons and can work together on the things where there are opportunities to across the divisions. Are there any more questions? Eddie, did you want to come in?
Yeah, just a kind of quick question, really, or thought. I think it looks all fantastic, and it's really amazing what can be done in that kind of perfect week idea. On the technology side, have you thought about kind of, not necessarily what we've got and what we can kind of offer out, but that kind of blue sky, what would make the whole thing better if you had that kind of technology? And have you included any of that in the business case of kind of thinking of some of those kind of big ideas?
We haven't, but I would love to sit down with you and talk about describe what I think would be the perfect model of what we'd want from an IT system. That would be great. I mean, the business case is mostly focused on staffing. It doesn't even really touch on the space as much, because at the moment that's our main area of need, and we didn't want to, ask the world in one go. But if you're willing to sit down and have a chat about what we could do in terms of an overarching IT thing, that'd be brilliant.
Yeah, because I think the interesting thing is, especially when you kind of got those different routes of referrals going in, it's how do you understand some of those kind of patients coming in, and how do you kind of route them through quicker? So I think it's an interesting space to try and see, can we just make that communication better around you as well? And
how can we then actually also, in terms of EMAS, can we feed back directly and say, of the 20 patients you sent in last month, 10 of them had to be admitted. We need to actually have a look at that, but have that data at our fingertips rather than having to retrospectively collect it. And the same with some of the 111 GP triage. Use it as an opportunity for education and feedback.
Definitely, yeah. And I think it's almost that kind of, is there a way of finding out the routing for that patient before they even ask the question?
Yeah, absolutely. Having that data at our fingertips live is what we need, really.
Perfect. We'll have a conversation then about how we can build that into the programme, both for medicine and for surgery, because we're keen to kind of, where we're doing work like that, have a shared approach. Stacey, did you want to come in?
I just wanted to say that I was over on your patch, Richard, earlier, and Richard was inserting a midline, and I do believe that it was to actually prevent hospital admission. So I just wanted to say that I found it very exciting as well, but it was on it. It was.
Yeah. Oh no, he's on it. I'm just putting the plug in for him because he just needs numbers now, and so he's up and running. He's putting in midlines, and it is all admission avoidance. It's all part of what we're talking about with SDEC. OPAT antibiotics. Admission avoidance. It's all part of the same thing, and it's a great service to have.
So it's already working.
Yeah.
Actually, on that point, Richard, I reflected as well on a conversation we had this morning about that communication and your reflection on how you would have done it differently. Could you just share that? Because I think that's important for sharing. It goes across other projects, I think, as well.
Yeah. So one of the things we were talking about this morning was we didn't put a lot of information out about SDEC to start with, and we're only really now starting to shout about what we're doing. There's sort of 6 months plus work in the background prior to the perfect week, and a lot of that was really about allowing ourselves to expand slowly. It has come with some negatives that people are still asking, what is SDEC? You know, I've heard of patients or GPs phoning up reception at the front door and being told SDEC doesn't exist, or people don't know what it is. So we have made mistakes along the way with the communication. It was a conscious decision not to be shouting about it to start with, because we didn't want to overwhelm the service straight away. And one of the things that we did mention is actually we would have preferred to have put the business case in 3 to 6 months ago, get the staffing in place, and then just say, no, we're here, come and use us, and really shout about it. I feel we've done it the wrong way around in retrospect, that we should have staffed it. We knew the need was there, and then really shouted about it and got the service up and running. But easy to say in retrospect, in hindsight, isn't it?
And you're also doing some great working, aren't you, with EMAS in terms of and how they can refer in. So you just share about that as well.
So, I mean, it was one of the senior paramedics broke his wrist just before the perfect week and got bored of being at home. So came in and sat with us and took some of the referrals from the paramedics. And he's now developing a teaching program on SBAR handover and how to refer in, because he's realised a lot of the junior paramedics or newer paramedics who don't necessarily do the standard handover in resus or haven't worked as ECPs, ACPs within the trust don't have that clear way of handing over a patient that allows the decision to be made about where they're treated. So he's now developing a teaching package for EMAS, and we're going to be looking at it and doing a bit of work. Neil Whiteley's leading on that, one of our charge nurses, on how we take referrals and sort of reflecting a bit on, are we taking referrals in the way that's most appropriate, and making sure it's just a polite professional conversation from both ends.
And that translates across into other areas of work. So in planned care, where we're looking at referrals coming in from GPs, that's definitely an approach that we're seeking to replicate, so that we can develop the right education and shared learning that prevents the referral, and having a GP work alongside us and looking at the referrals kind of adds value, doesn't it, in a different perspective on things, which can help us with the shared learning back.
Absolutely.
Thank you so much. I don't think we've got any more hands up. So we look forward to hearing how it develops for the future and about how we develop our shared services with SDEC across the trust. Thanks, Richard. Moving on then, so Hannah, are you going to talk to us about MSK physiotherapy virtual appointments?
Yeah, so I'm Hannah, one of the senior MSK physiotherapists, and I'm just going to talk to you about recently we did an improvement audit of our virtual physiotherapy MSK appointments, and which took the form again of a survey monkey. So just to tell everyone what we sort of included in the survey. So the aim was to establish our patient satisfaction with our virtual physiotherapy appointments, which were completed both by telephone and by video. The survey had 9 questions, and it collected both qualitative and quantitative data. So the quantitative data was collected on a Likert scale, so sort of strongly agree ranging to strongly disagree. The final question was if patients were to choose whether their the next appointment was a virtual or a face-to-face, which one would they prefer? And the survey was implemented in July last year, obviously during the pandemic, to try and get a bit of an idea about what patients liked and didn't like about our virtual appointments. Next slide, please. So survey questions. So first of all, we collected a bit of demographic data. So patient age, reason why they were referred to physiotherapy. So was that for more of an acute injury, such as a fracture, or whether it was more of a long-term chronic condition. Asked them whether it was a telephone or a video appointment which they'd had. Asked questions about convenience of their virtual appointment, whether they felt the physiotherapist was able to identify and understand their problem from the virtual appointment, the ease of understanding the physiotherapy advice, whether the patient found the physiotherapy advice helpful, and then the overall satisfaction of the physiotherapy care. And then the final question, as I said, was if they were to have another appointment, would they prefer a virtual or a face-to-face appointment again? And as I said earlier, each question included a text box for qualitative comments, so we could collect a bit more data. Next slide, please. So data trends over time. So we've done two cohorts of patients. So autumn 2020, we did an analysis of the survey responses so far, and then spring 2021, and we'll just sort of compare the data between the two. So 85% of virtual appointments in autumn 2020 were completed by telephone, as opposed to 92.5% in spring. This possibly reflects the increasing use of face-to-face appointments, and probably clinician choice to do telephone over telephone over video, because of the technological difficulties encountered whilst using video, which Carolyn sort of alluded to earlier. Patients were treated for more acute injuries in autumn 2020, obviously due to the service and the pandemic. And in spring 2021, we sort of re-established our services. More of our staff had come back from the wards after being redeployed, and we were treating more of a variety of acute and long-term conditions. Only 2.5% of patients did not find their virtual appointment convenient in each cohort, so majority of them did find the appointment convenient. Next slide, please. So patients felt that a physio could identify and understand their problems slightly better in autumn compared to in the spring, so that's 92.5 compared to 87.5% of patients in the spring. We think this may have reflected the sort of reuptake of the self-referrals and the complexity of the conditions and the complexity of the assessments, possibly in the spring compared to the autumn, where most of the patients had acute injuries or conditions that had already been diagnosed. More than 90% of each cohort agreed or strongly agreed that their physiotherapist advice was easy to understand and helpful, so that was good. Next slide, please. Sorry. Oh, yeah. Overall, patients were slightly less satisfied with the physiotherapy care delivered via virtual appointments in spring 2021 compared to in autumn 2020. So again, we think this may have reflected sort of patient expectations and the sort of the shift in patient expectations from initially during the pandemic, where people were happy to be getting any appointments and any physiotherapy at all, really, compared to this year when patients expect that physio to be more aligned with their perceived normal, and that's sort of as regards sort of hands-on treatment and things like that. When given the choice, patient preference was for a face-to-face appointment over a virtual appointment in both cohorts, and you can see that this has risen over time. So from autumn 2020, that was 57% majority, to spring 2021, that's now 60% would prefer a face-to-face rather than a virtual appointment. Next slide, please. Thanks. So conclusion, so virtual appointments are preferred by some patients. Patient satisfaction remained high despite changes in service delivery. Initially, obviously we were giving everybody face-to-face appointments. When we moved to the virtual appointments, initially during the first lockdown in March, people were quite satisfied with that still. Some patients do value face-to-face and hands-on assessment. Patients do appear to value a combination of face-to-face and virtual. So a lot of the qualitative feedback we got was that they would, prefer a bit of a mixture of the two. Next slide, please. So limitations of our audit, so it just reflects patient satisfaction rather than the clinician's judgment on the required appointment type, really. No clear differentiation between patient satisfaction levels for telephone and video appointments were made, so obviously it included both, but the majority of our appointments were done by telephone. Clinician burden, so actually to get this survey out after each virtual appointment, the individual clinician had to send a manual email to each patient's email address. So that may have limited our sample size in the fact that maybe the emails weren't sent 100% of the time. And the potential bias towards the technologically literate population. So if people didn't have internet at home, they were unfortunately unable to participate in these surveys. Next slide, please. Okay, so actions to come out of this. We're looking at developing a new therapy patient experience measure, trying to differentiate between face-to-face, video and telephone consultations, and that's looking to include the family and friends test too. We're looking to evaluate the clinician's opinion and the satisfaction with the virtual versus the face-to-face methods. We're looking to correlate patient satisfaction and the data that we've collected against other clinical outcomes, such as other outcome measures, the complaints rate and the re-referral rate as well. And we're considering other alternatives for capturing this patient satisfaction to reduce the clinician burden. So I think the Trust are looking into getting this text up and running and linked with our system one with our patients, so that we don't have to send these links out manually anymore. And that's it. Yeah. Any questions?
Brilliant work, Hannah. It's really great to see that comparative view as well, to kind of how to see the two different time points. I think there were a couple of things that we're grappling with as an organisation. The first is the case mix impact and how that is impacting the format of our appointments, because we across the specialties, we're thinking that we've got a cohort of patients who haven't been in for a while, so do they now need to come in and be seen face to face, whereas ordinarily they would just be on a maybe reviewed virtually, and whether that's skewing our results at all in terms of what we're currently seeing isn't our kind of forward baseline, if you like, in terms of normal activity because of that complexity of case mix. The other thing was inequalities, which we're really focused on. So the new NHS priorities and planning guidance for the has just come out, and as a joined up care Derbyshire system, we are seeking to collect some new data around the demographics of our use of outpatient measures like non-face-to-face, video, telephone, patient-initiated follow-up. And what we want to do is have a look at are we identifying any inequalities in that we need to mitigate against and take any action on? So that's definitely at the forefront of our mind about thinking about digital exclusion and how we might address some of that as a whole system. Are there any other questions for Hannah? No, fabulous piece of work, Hannah, and we look forward to you coming back. I'm really interested in that, the clinician view on things as well, and if you could bring that back when that's done, that'd be fabulous. Thank you.
Yeah, thanks.
Stacey, shall I hand over to you to talk about bringing improvement to life?
Afternoon, everyone. So really bringing improvement to life, I just wanted to talk to you really. I've obviously been tucked away vaccinating for a while, and as everybody's alluded to, we're starting along the road to recovery. So as part of my role now, I've linked in with a lot of the matrons who are completing their ACE assessments on the wards. And actually it's so refreshing because everybody is really up again for improving and change, and really up for the challenge of improving care for the patients. So a lot of my work at the moment is tied up with with the matrons and helping them develop their ward improvement plans to improve patient care and staff's working lives as well. I think I was going to touch about something else and I can't think what. So the only other thing is that me and Victoria are doing the virtual improvement forum. We've now taken that face to face, with hopefully making that more accessible to a wider audience of people that don't particularly like sort of the Teams technology. And this is for absolutely anybody that's got a improvement idea. So it's not as in-depth as CUSA, but it will springboard and start your project off. You'll sort of you'll come along and you'll learn where to start your project, how to start thinking about measures and improvement. Hopefully that you'll leave feeling even more inspired than you were before, and that improvement and change isn't a difficult task to do. Once you've come on that as well, you've sort of got real unlimited resources with both myself and Victoria. We're there to support you all the way through your project, so we can actually get an end, hopefully a sustainable end result of your project as well. So it's just a little bit of a plug. And that's me.
Thanks, Stacey. Yeah, get in touch with us if you've got an improvement idea that you'd like to bring to life, and we can. There are multiple ways you can get in touch through the QR codes on the posters around the trust. Email us, ring us, get in touch, and we will support you with bringing your idea to life. Next slide. Thanks, Victoria. So we have the newsletter as well that gets distributed across the trust. So Victoria and Stacey really take a lead on putting this together. If you've got an improvement, big, small, in progress, completed at the start, get in touch. We want to share and celebrate success. So please let us have contributions for that, and hopefully you can start to see that in your areas being distributed, and there's another forum by which we want to share and celebrate our improvement success and our improvement work going forwards. Improvement training program. So Stacey's really just talked to this. So we've got our introduction to improvement, which is a short session about you come along. We talk you through the improvement methodology and change and the basics of that. How you can develop your aim, how you can work out who your stakeholders will need to be that you work with, how you can measure your improvement, and then start to test an idea. The session's about 3 hours. We were doing it online, but as Stacey said, we've found that not everyone's got access to do that. So we've taken the sessions back face to face in the Innovation Centre, which is all socially distanced, and we're all good in terms of how we deliver that face to face. So please get in touch if you want to come into one of those workshops. We can as well. We've been talking to the divisions about perhaps offering that on a team basis as well. So if you're a team in a particular clinical area or a corporate area, and you've got an idea that collectively you want to work on, we could offer that session to you as a team and help you develop up your improvement idea and how to go about making that change. Next one, Victoria. So just a couple of slides about sharing and celebrating success, just things that we've been made aware of as an improvement team across the trust. So we've been doing lots of cancer, raising awareness about our cancer, and we know through the COVID pandemic that we've got a huge unmet demand in terms of people presenting with suspected cancer. So we've been really focused on videos raising awareness. Our lead skin cancer nurse specialist Nicola has done a video this month on Sun Awareness Week, encouraging our patients to prevent if they've got a worry. We launched our long COVID support group for staff and a new way of supporting staff who've been affected by long COVID. You'll be aware if you've been at this forum before that we've talked about in the past about David Sandler's And I Look Like This campaign, and that continues to get publicity and spread with other trusts adopting the approach and some focus in the Nursing Times this month. Next ones, please. So we've got, these are both kind of adverts really for training that people can get involved with. We're particularly focused at the minute about how a simulation training can benefit learning for the future. So we've got a new session coming up in a couple of weeks aimed at developing use of simulation training. And in the Joined Up Care Derbyshire space, the Quality Conversations programme has been relaunched. So it's a programme that's been there before, and it's really focused on developing conversations between clinicians and patients. It's a really great session. I definitely encourage you to get involved with that. And it's open to staff across Joined Up Care Derbyshire. So the sessions are run with people across different organisations, which again supports the shared learning in the environment of delivery of that programme. Next slide, please. So hopefully you'll have all seen that we finally launched our Together as One 5-year strategy for the Trust last month. As a Royal Academy of Improvement, we're incredibly excited that Bring Improvement to Life is one of the Trust's top 5 objectives, and that's what we're here to do. That's hopefully through these sessions that we do in terms of sharing, celebrating and supporting and giving you a route to get support to bring improvement to life. If there are the couple of things that we highlight at the end of that report, again go into the reporting that our hospital leadership team see and our finance and performance committee. So if you've got things that you want to share and celebrate, again, please let us know. We'll put them in the improvement forum in this slide set, and then they feed into the wider organisational reporting about improvement as well. Next slide. So that was, we've got a couple of minutes left at the end. So are there any people who want to talk about any improvement ideas that are being developed at the minute? Any improvement work going that you'd like to share or celebrate or talk about for a future improvement forum? Helen.
Hi, thanks, Maria. It was just to say that the simulation training day that we've got a week on Wednesday, there's still 4 places left for anybody that's interested. We've also started our human factors modules again, teaching modules, and we're doing those virtually at the minute and hoping to go back to face eventually, or a mixture of the two. So there's dates coming out for those also. So just to watch that space as well for the training.
Brilliant. Thanks, Helen. Anybody else? No, well, thank you very much for your time, everybody. Thanks for joining us, and we hope to see you again next month. If you do want to showcase your improvement on next month or later in the year, please get in touch with us. Thanks very much. Bye.
Thank you. Bye.